I'm Ms. Mahadev, Dr. Murad. I to examine your legs for venous disease. Is that okay with you?
Yeah.
Could you please stand? All patients with suspected chronic venous insufficiency should be examined in the erect position. This will accentuate any superficial varicosities. The examiner should be seated at a comfortable level to examine the entire lower limb. Focus your attention to the superficial varicosities. Course the great saphenous vein, which arises from the deep venous arch and runs anterior to the medial malleolus along the medial aspect of the calf and thigh to pierce the cribriform fascia at the fossa ovalis and enter the common femoral vein. The surface marking of the saphenofemoral junction is said to be 4 centimeters lateral and 4 centimeters inferior to the pubic tubercle. Do not forget to examine the posterior aspect of the leg, as the short saphenous vein runs posterior to the lateral malleolus along the mid-calf between the heads of the gastrocnemius muscle to enter the popliteal vein within the popliteal fossa. Observe the size, site, and extent of the varicosities. Look for obvious edema in the ankle region. Look particularly at the medial aspect of the leg for lipodermatosclerosis, which is caused by chronic venous hypertension, resulting in progressive sclerosis of the skin and subcutaneous fat. It is represented by darkening of the overlying skin. One could also look for venous ulcers, which are typically shallow and painless with an irregular border. Healthy granulation tissue is usually present below, unless infected. Continue with inspection palpation. Erythematous, painful lump. Next, palpate the saphenofemoral junction. Tap along the great saphenous vein in the mid-thigh. A significant fluid thrill indicates the presence of a saphenous. Do not forget to look for Dodd, Cockett, and Hunterian perforators. Palpate the deep fascia for obvious defects, which may indicate the presence of perforators. Focus on the ankle region and examine for pitting edema. To perform the Trendelenburg test, we ask the patient to lie down and elevate the leg. The leg is elevated to empty any varicosities. With the leg elevated, we now occlude the saphenofemoral junction. With the saphenofemoral junction occluded, we now ask the patient to stand quickly. If the varicose veins do not refill immediately, then it means the patient is likely to have saphenofemoral incompetence. If the veins refill quickly, then there must be perforators distally. The tourniquet test can be used to determine the site of the incompetent perforator. Again, the patient is asked to lie down and the tourniquet is placed on the upper thigh, lower thigh, and below the knee. Again, the patient is asked to stand. If the tourniquet controls the varicosities, then the defect must be above the level of the tourniquet. Both the Trendelenburg and tourniquet tests have been replaced with the use of a handheld Doppler or duplex scanning. These tests yield a more accurate assessment of the level of incompetence and venous valve malfunction. The role of percussion is minimal. However, palpating a distal thrill on percussing more proximally indicates an intervening incompetent valve. A vein may be dilated even on lying down with the leg elevated. This may indicate the presence of thrombosis or an AV fistula. Auscultation revealing a venous hum or bruit may indicate the presence of an AV fistula.